Well, we love doing it.
All right, guys, I'm recording this. And because I finally remembered to do it, I acted when my memory was working. So don't say anything you want to take back. All right. On the other hand, if you want to talk about the present administration, be my
Oh, somebody will be listening.
right.
Yeah, Musk will. He's got all our records.
Been reading about the Kennedy Center.
All right. Oh, Sandy, I'm thinking of you.
Richard, I'm a guide there. I give
Oh,
tours. I give
oh,
tours.
Sandy, that's great. I just was there to see the Reach and I picked up that new brochure all about the activities in April,
Yeah.
about
Yeah.
the moon and outer space, and it sounds wonderful.
Yeah, I know.
Are
No
you
more.
going to give a special tour for that?
No, well, we actually, maybe we could do it again. The salon went and had a tour of the Kennedy of the Reach
Ah,
a while ago before all of our new members.
hmm.
It's really interesting inside. It's better inside than outside.
I love both.
Oh,
Yeah.
you do? All right, well,
Yeah.
it's a discussion you and I should have about it.
Yeah, I've never been, so that would be fun.
I, those pieces look like tokens for Monopoly. All right, well,
I'd suggest
still
we get a
letting
couple of
people
new
in.
pairs.
They're at home.
Any news, anybody? Good news?
Not good news.
Is there,
Sandy, why don't you tell them about Wonderland? Tell them, because even though we talk it up, a lot of people don't know.
oh, well, you know what? You do it, because I don't want to use the salon as a platform for telling about Gail's bookstore. So you
Right.
tell.
Okay, well, Sandy, who is a long life friend of mine, and her daughter Gail, who I've also known, Gail and a friend have started a bookstore in Bethesda, an independent bookstore called Wonderland Books. It's on Norfolk Avenue, and it's where Comfort One shoes used to be. And it's precious. It is just a beautiful little welcoming place. Has all kinds of books, everything, from fiction, nonfiction, cookbooks,
Travel.
travel,
Children,
health, children's, and all kinds of little gift things like socks and great socks and cards. And it's just wonderful to have an independent bookstore again in Bethesda. So I'm doing this for Sandy, but I'm doing it for Gail, and I'm doing it for all of you because it's a great little place to go.
Thanks, Marge. Gail just forwarded to me um, a letter that her business partner, I always had, wrote to Sebastian Smee. You all know who Sebastian Smee is? The art critic,
Yes.
the art critic of the Post, right? And apparently he's written a book, and he's going to come and appear at the store.
Ah,
Which group is this?
send us the date when he decides.
Yeah, okay, I'll do that. Hi, Debbie.
Hi there, Sandy.
Debbie is a guide at the Kennedy Center with me, and she alerts me ahead of the Washington Post about what's going on there.
Which is not a pretty picture.
Right.
I don't think he's ever even been in Kennedy.
Right. That's what.
That doesn't stop him.
I know he was never interested before. All of a sudden, it's a grab game.
Mm.
All right, everybody, somebody's got something on in the background, and then we'll mute you all. But before we do that, Marge, will you tell us about
Right.
March's program?
Okay, so March's program is also going to be on Zoom. Somebody has something on.
Yeah, you
It's
know what?
Augie, I think.
Who is it?
Who?
Augie.
Oh. Anyway, it will be a Zoom because of the weather and because we're in Friendship Heights and it's a bit hard to park here. And Kathleen, who is going to be our speaker, has also just had some foot surgery. And I don't think she's going to be getting around. So this will probably be in the first week of March. And I think this will be you had selected, I wasn't there when you selected this, but I think she can do a combination of two things. You selected that the El Camino trail in Spain and it's other places, but she was going to talk about hiking on this trail and what to expect. But she's also, and I think this Richard, I think you may know her, or she could follow up with yours, which is she's a volunteer commissioner on Montgomery County's Commission on Aging, and she knows the resources for older adults in living active, healthy, and independent lives. And she'll also talk about the programs and services for older adults, including wellness and recreational activities, caregiving resources, transportation options and opportunities. She's a senior care specialist dedicated to helping individuals and families navigate the complexities of aging. And she was just honored with the prestigious Deb Levy 2024 Grows Humanitarian of the Year for the award for Montgomery County. There are other things, but I don't want to take too much time. So that's what's going to be happening in March. And as I said, it will probably be the first week. So I'll send out a thing. Sandy, is it better to do it in the afternoon, the 4 o'clock?
Well, traditionally, Zooms are in the afternoon. Today is an exception.
Right.
Because your time had already been set aside for this meeting. So I just
We'll
figured.
do that. It will be in and after the 4:30 or whatever.
Okay, and offer 2 dates.
Yep.
And I will also say, for planners, that when you are the planner, you're entitled to invite other people to the meeting. Okay, all right. At this point, I'm going to mute everybody, and then I'm Marilyn and Richard, unmute yourselves.
Andy, could you tell us who iPhone 39 might
Stay
be?
in here, or what are you gonna do?
Going to meet him?
Yeah, I can't hear with that on.
Well, I'm going to mute everybody, and then it'll,
Beth,
I'm sure, get quieter.
you come in and unmute me.
Okay, all right, here goes. Here goes.
They can hear you.
Mute all. Okay, you're all muted except me. A lot of power. Oh, Richard, you're unmuted. Good. Marilyn, unmute yourself. Unmute. Well, maybe I can unmute you. Let's see. Let's see. You got to unmute yourself. Can you do it, Marilyn?
Now you're
good.
unmuted.
Oh, good. All right. So, Richard, thank you so much. You come with a lot of hype because Marilyn just speaks so highly of you. So, thank you so much for taking the time to be with us today. Okay, Marilyn, it's yours.
Okay, well, I just have a few words of introduction. There's no way to do justice to Rich Eisner's credentials in just a few minutes. So this is just the very tip of the iceberg. We met Rich and his wife Joan when we first moved into Somerset. And we found that we immediately had something in common, and that's that Rich and I both grew up in New Jersey. Rich grew up in Newark, New Jersey, and then he went to college at the University of Pennsylvania. And I think he said in his bio that he wound up spending 50 years there. And just by chance, while he was there, he took a course on neuroscience. No thought that it would ever have anything to do with his career. But then he went to medical school, and at the University of Pennsylvania. Wait a minute, I'm not sure I'm right on that. So, Rich, you'll have to correct me if I'm wrong. And he stayed interested in neuroscience and was published in a journal called Brain Research. He did his residency in neurology at Pennsylvania Hospital and then practiced neurology at Bryn Mawr. And Bryn Mawr Hospital, for those of you from the Philadelphia area, you know that Bryn Mawr is suburban Philadelphia, and he worked at Bryn Mawr Hospital for 39 years. Simultaneously, he was a neurology consultant, and maybe still is. You may have to bring us up to date on this, Rich, at Haverford State Psychiatric Hospital and Community Volunteers in Medicine, a clinic for uninsured migrant workers. So hats off to you for doing your part in that world. And from my perspective, there couldn't be a better grandfather anywhere around. Rich is a very devoted grandfather and has his grandchildren here frequently, and sometimes they come and ring my doorbell and want a cookie or a piece of chocolate or something like that. And he and his wife, Joan, who's a social worker, and her passion is genealogy. We should have her come talk sometime about genealogy and what she's learned from it. Anyway, thank you for being with us, Rich. We appreciate it greatly. And now you can correct anything I said that ought to be corrected, and you're on.
Okay. Can you hear me okay?
Yep.
Good. Okay. Well, Marilyn, thank you so much for that introduction. And you got it mostly right, I'll say.
Mostly.
Okay. So my wife and
Well,
I.
my professors always said mostly. Wasn't good enough.
My wife and I moved to this area to be with our family about a year and a half ago. And I think on the second day of our new location, the first person I really met in our building was Marilyn. And about 3 hours after I met her, I had an invitation to go out to dinner with she and Steph, with my wife. So Marilyn's been very welcoming to me and just a good friend. So I'm very happy to join with you today. And yeah, I'm very happy to help out Marilyn. So as Marilyn said, I did practice clinical neurology for many years, but I've been retired now for 5 years, and that's been a big change. I mean, these days, as Marilyn said, I mostly take care of my grandkids and have a lot of time to myself, which is kind of wonderful. But I'm very happy to talk to you about a topic that I think that's is very relevant to probably everyone who's listening, and very relevant to myself. And recognizing that, we'll be very sensitive and kind of talk about these issues. I want to give you a brief outline of what I'm going to be saying. First, I'm going to be making some general comments about aging. And then I'm going to go into more detail regarding normal aging. I'm going to address the diseases of the aging brain and new developments in diagnosis and treatment. And then finally, I'll review the science of what we can do to preserve our brain function. And we'll have some time for questions. So So let's begin actually a few centuries ago. So Thomas Hobbes, in his 1651 book, Leviathan, argued that human life without government would be nasty, solitary, poor, brutish, and short. And certainly he was correct in describing life expectancy throughout most of human history, with government or without government. Psalm 90 of the book of Psalms tells us that the years of our life are 70, and clearly some survive that long. But many succumbed at an early age to either violence, starvation, or infectious disease. What we now call dementia was not unknown. Shakespeare was able to create a character like King Lear. However, people were much less likely to live long enough to exhibit the symptoms of the aging brain. Even as late as 1900, life expectancy was only around 40 years. Now, of course, this was diminished by a high infant and child mortality. But when I moved to Washington, I had to think of a way to try to express to Washington people this dramatic change that's occurred. And so let's think of the American presidents from Andrew Johnson, number 17, to Calvin Coolidge, number 30, so we can kind of bracket the year 1900. Of those 14 presidents, only 3 survived into their 70s. The oldest was Taft, who lived to age 72. So things have really changed quite dramatically. In fact, the fastest growing demographic group in high-income countries right now are the oldest adults, those over 90 years of age. So what's happened? Well, violent death has much decreased. The agricultural revolution has made food more available. With the exception of our occasional pandemics, we treat infectious disease much more capably. And perhaps most important, medical science has made great strides in treating cancer, chronic diseases such as hypertension, diabetes, heart disease. And all these are all the things that prevent us from living beyond Psalm 90's limit of 70 years. And life expectancy now is almost doubled. Now it's approaching 80 years. So now let's turn to the year 1901. In Frankfurt, Germany, a woman named August Detter was admitted to the hospital. She had abruptly accused her husband of adultery. She had delusions. Her memory decreased rapidly. She was careless with housework, hid items intentionally, and lost her ability to cook. She experienced difficulty writing and in conversation. She developed insomnia, lost her sense of direction. She dragged a bed sheet outside, wandered around wildly, and cried for hours. Her physician was Alois Alzheimer.
I'm on a Zoom call.
Alzheimer had demonstrated a talent for science early in life and pursued a career in medicine.
Hey, we lost you. We've lost you. We've lost
No
you.
audio. No audio. No audio.
Okay, can you hear me now?
Yes.
Okay, good. Maybe I should back up a little bit. I was describing the patient. Did you hear that? Can I ask? Did you hear that?
You had
Yeah.
just introduced Dr. Alzheimer.
Okay, good. Okay, then we're good. So Alzheimer had demonstrated a talent for science early in life and pursued a career in medicine. He married a wealthy widow and thus could devote himself to research without any economic constraints. Alzheimer collaborated with a neuropathologist named Franz Nissl, who taught him techniques of staining neurotissue for microscopic observation. He eventually He eventually began to work with Emil Kraepelin, who was a famous psychiatrist. And in 1906, Alzheimer learned of the death of his former patient, August Detter, and obtained her brain material for investigation. He observed and described what we now call senile plaques and neurofibrillary tangles, and these have ever since been the neuropathologic signs, the defining signs of Alzheimer's disease. However, the presentation of his findings did not gather much interest. Kreplin, the psychiatrist, wished to promote Alzheimer's discovery and included them in his widely read 1908 textbook, Psychiatry, proposing to call the illness Alzheimer's disease. Alzheimer's disease was felt to be a rare pre-senile condition, and this is where things stood when I was in medical school in the mid-1970s. And there's one aspect of the story, actually, I withheld from you, and that is August Detter, Alzheimer's original patient, died at the age of 55. So today we would say she just had a very rare Alzheimer's variant and not typical Alzheimer's disease at all. Ironic. Our modern understanding of Alzheimer's disease began just a few decades ago in 1976, when Robert Katzman at Albert Einstein Hospital in New York published an editorial in the Archives of Neurology. He explained that senile dementia, as it was called then, is not normal aging. It is a specific disease, namely Alzheimer's disease. In addition, he explained that Alzheimer's disease is the most common cause of dementia and one of the leading causes of death in the world. In 1977, which we should think of as quite recent history, 1977, he organized the first Alzheimer's disease symposium in the United States. So research funding grew rapidly from a pittance to a huge amount. So these are very recent developments. So here's where I come in. I started my training in neurology in the summer of 1978. To remind you, this is a few years before MRI machines came into clinical use. My hospital was very proud to have one of the first CT scanners in the city of Philadelphia. At the time, the medical community had very little interest in the aging brain. Families were given the message that their loved ones were suffering, but there was little to do. They should simply figure out a way to manage, and there was no need to return for medical care. I had been taught that these patients need an evaluation to rule out potentially treatable causes of their symptoms, but otherwise there was nothing more to say. At the time, I was 30 years old, and the world of these patients and their families was really totally beyond my comprehension. When I spoke to patients, or for that matter, non-neurologists, they all knew what caused dementia. It was hardening of the arteries, a vascular problem. I must have heard that term 1,000 times. And yet in the world of neurology, it was now recognized that this was a specific illness with unique findings whose cause was unknown. So almost everything I'm going to describe to you was the journey I lived through over the course of my career. So now let's turn to the effects of aging on the brain. There's tremendous variability in age-related changes of cognitive abilities. Differences in the degree to which individuals' cognitive function changes with age are due in part to a lifetime of differences in experience, health status, lifestyles, education, emotional factors, socioeconomic status, and genetics. The trajectory also varies for different cognitive functions. Some aspects of cognition decline with age, while others show improvement or remain stable for decades. Humans make errors throughout our lives and struggle to perform optimally. That is not a disease, that is being human. No one's brain functions perfectly at all times. However, human aging does result in changes in many functions that exacerbate that tendency. Typical examples include a generalized slowing of brain processing speed, attention span shortens, spatial ability declines, word finding failures increase. Memory function becomes more difficult. In fact, it's been well established that memory function capability starts to diminish about after the age of 30. Have you tried playing memory games with your grandchildren? They beat you every time. Now, remember, none of these cognitive functions were performed perfectly in our youth. However, crystallized intelligence, which reflects a person's knowledge, tends to remain stable. Procedural memories, such as how to perform complex motor tasks like riding a bicycle or playing a musical instrument, remain intact. Wisdom, which emphasizes the application of knowledge, will often, hopefully, increase. Now, are these changes surprising? Should we consider them a disease? No senior citizen expects to run a 100-yard dash as fast as they did 50 years ago. We don't consider that a disease. How do we distinguish normal aging from dementia? Well, importantly, the symptoms of normal aging do not noticeably disrupt daily life. They do not affect your ability to complete tasks. Although it may require some more effort, you can learn and remember new things. Occasional forgetfulness or difficulty finding a word or recalling his name is not dementia. Occasional forgetfulness or difficulty finding a word or recalling a name is not Alzheimer's disease. I just want to emphasize that. So what is happening in our brain that accounts for these aging effects? Now here is a 30-second course in neuroscience. The nerve cells of our brains are called neurons. They have a cell body and an appendage called the axon, which extends to the vicinity of other nerve cells. The axon releases chemical messengers, which are recognized by a special receptor apparatus on the area of a second neuron that we call the dendrite. That either makes the second neuron more or less electrically active. This connection between nerve cells is what we call a synapse. Well, that's enough. So you're all now neurologists like me. Perhaps surprisingly, there is a lot of evidence that we're not losing cortical brain cells or neurons as a result of normal aging, but many other changes have been observed. There is a change in the number and function of the connections between neurons, that synapse I just referred to. This occurs most critically in the area of our brain that we call the hippocampus, which plays a major role in memory. There's a loss of the ability to rewire our neural connections, which we refer to as plasticity. So normal aging changes are extremely common, but they are not Alzheimer's disease. So now let's spend some time talking in depth about Alzheimer's disease itself. I'm going to surprise you by beginning with something you'll find very encouraging. The percentage of people who are diagnosed with Alzheimer's disease is decreasing. We have more people who are living longer, so we see more people with Alzheimer's disease in total, but the percentage is decreasing, and this seems to be due to various preventative measures, which we're going to be talking about, but the adherence to these preventive measures is having a significant effect. Equally important is that, we may be on the cusp of a possible revolution in diagnosis and treatment. Now, dementia, I'll remind you, is the general term for a progressive cognitive loss, of which there are many causes. Alzheimer's disease is the most common cause. I'll define Alzheimer's disease as a neurodegenerative disease marked by behavioral changes, particularly memory loss, and associated with a loss of brain cells and the neuropathologic findings of these senile plaques and neurofibrillary tangles that Alzheimer saw himself over 100 years ago. We now know that these plaques are composed of proteins that we call amyloid and tau. There is some significant controversy regarding the cause of Alzheimer's disease, whether it's related to amyloid and tau. The issue is whether the deposition that we see in the brain cells of people with Alzheimer's, is it truly the cause of the illness or just what we call in science an epiphenomena, something that's there but not actually the cause. There are some recent findings suggesting a sequence of events in which people do develop amyloid in the brain and then tau and then clinical symptoms and volume loss. But this is still a very significant controversy. The amyloid theory, however, has been the basis of new approaches in diagnosis and treatment, and we're going to talk about that. Now, the process of diagnosing Alzheimer's disease starts by obtaining a history, typically from a family member, and then noticing and documenting behavioral and mental status changes. Simple and reproducible standardized cognitive tests can be administered, and a diagnosis can, in addition, be found by neuropsychological testing if necessary. We always have people undergo a series of blood tests and brain scans to look for other potential causes. Genetic testing of a gene that we call the lipoprotein AE gene was first reported about 20 years ago and can show us whether someone has a greater likelihood or lesser likelihood of developing Alzheimer's at some point in their life. In addition, tests were created that could document the deposition of amyloid and tau in the brain, measure the abnormal levels in the brain spinal fluid. We could measure the brain's metabolism and look for evidence of Alzheimer's disease. These were all developed, but during my career, none of these changed our treatment approach, and we just did not utilize them. My patients and I were encouraged when the first treatment for Alzheimer's disease was approved in 2004. It was marketed under the name donepezil. It was donepezil, which is marketed under the name Aricept. And it boosts the level of a brain chemical called acetylcholine. This clinically had the effect of pushing back the illness about 6 months. It was quite well tolerated and widely used. It was approved for all the stages of Alzheimer's disease. And although it was not a wonder dog, I was really glad to finally have something to offer my patients. A few years later, memantine, marketed under the name Namenda, which blocks a different neurotransmitter, was approved for moderate and severe Alzheimer's disease. This drug also had modest benefit and a reasonable side effect profile. These two drugs were often used in combination. Then things began to change. Treatments were designed to try to eliminate amyloid deposition by the use of monoclonal antibodies, which have been shown to have a clinical benefit. Now, monoclonal antibodies, very simply, are antibodies produced by cloning white blood cells against a specific foreign substance, in this case, amyloid. Now, in addition, a simple blood test has now become available to assess amyloid and tau, and you can get this blood test, clinically in laboratories. And these events may well be radically changing our approach to the diagnosis and treatment of Alzheimer's disease. So let me review some recent findings with you. First, a controversy arose in 2021 when adumanucab, a monoclonal antibody directed against the amyloid protein, was approved by the FDA after an expert panel had voted to deny approval. Although there was evidence that amyloid was diminished in the brain with this treatment, there was no evidence of any clinical improvement. After much discussion, Medicare declined to cover the cost of treatment outside of clinical trials, so that was basically abandoned. Lecanemab, now marketed under the name Leqembi, a similar monoclonal antibody, was given accelerated approval in January 2023, and later full approval for the treatment of mild cognitive impairment, we'll talk about that soon, and for mild dementia. It has been shown to modestly slow cognitive deterioration over 18 months. It is delivered by an intravenous infusion every 2 weeks. Side effects are a definite concern and include brain hemorrhages and brain swelling, which occur in about 10% of patients, although often asymptomatically. A thorough discussion of benefits and risks would be necessary before committing to a treatment like this. There's been limited acceptance, just a few thousand patients who've been under treatment. The cost of treatment on a yearly basis is $26,500. The manufacturer Eisai has calculated the per patient social value as $37,600, and I will allow you to make your own judgment of that concept. Most recently, donanemab, another monoclonal antibody marketed as Kisunla, was approved in July of 2024. This clinical improvement, like with lecanemab, is modest. However, half of the patients under study showed no worsening over the first year on treatment. These developments are creating new and exciting opportunities for treatment, but also raising many new questions. Should we be defining Alzheimer's disease strictly on the basis of biochemical findings? Should we be treating asymptomatic people who demonstrate amyloid deposition or have genetic markers in the absence of symptoms? Should we be screening our population from an early age for the presence of amyloid and for the genetic risk? There are now studies ongoing to answer these questions, but we don't have the answer today. Now, before we leave the discussion of Alzheimer's disease, I think I have to comment on those wonderful commercials that you are inundated with on television, where people give their testimonials regarding the benefits of Prevagen and Nariva. I'll start by repeating the snarky saying that those who study statistics like, which goes, the plural of anecdote is not data. I'll repeat that. The plural of anecdote is not data. Yes, I had many patients ask me about Prevagen. I was very puzzled when I first saw the commercials, and I learned to pay careful attention to the very small print at the bottom of the screen, the wording there was curiously shared word for word by Nariva. I'll read it for you. Quote, "These statements have not been evaluated by the Food and Drug Administration. This product is not intended to diagnose, treat, cure, or prevent any disease." Unquote.
Jesus.
Now, I could spend a lot of time explaining how their studies are worthless and their claims misleading, but if you have some spare time, you can Google this and satisfy yourself. And if you're wondering how we allow ineffective treatments like this to be promoted, just Google the supplement industry and donations to Congress. Now, I have to interrupt to give you an anecdote from my life. Not long ago, I was in a local pharmacy waiting for my COVID booster when I found I was seated next to their brain health and cognitive support aisle. So intrigued, I knew I had to investigate, and there I found the following products: Cognitive Health, Cognium, Equizen, Neurogum in both cinnamon and peppermint, Brain Fog, Brain Health plus Multivitamin Women's, Mind Ignite, Recollection, NeuroBoost, Genius Consciousness, Genius Mushrooms, Michael Botanicals Brain, Lion's Mane, I love that one, Mind Restore, Focus Factor F29 in regular berry and orange flavors. I'm speechless. So let's briefly discuss the term mild cognitive impairment. This concept evolved over the last few decades to describe a state of cognitive function between normal aging and dementia. People with mild cognitive impairment suffer impaired memory or other cognitive deficits not normal for their age. However, they are functionally normal. They can drive a car, pay bills, speak fluently, and essentially appear normal. So this term has been used to try to identify the clinical spectrum of dementia earlier than Alzheimer's disease. Can we conclude that people with mild cognitive impairment who have amyloid or tau in their brain or who have genetic markers will go on to Alzheimer's disease? This is not completely clear. Some people with mild cognitive impairment do go on to develop Alzheimer's disease. Others stay stable or even improve. No oral medications have demonstrated to help mild cognitive impairment, although they are often prescribed. However, note that the monoclonal antibodies actually have been approved for that condition. So now let's talk about the many strategies we can use to preserve our brain function. What can we as individuals do? I'm going to give you a long list of things that you can do based on our latest scientific data. I've counted 15. But first, some important caveats. Many of the recommendations that I will discuss cannot be thought as totally independent of each other. If you follow one, you're very possibly following many of the others. Secondly, it's difficult to distinguish what's truly a cause of benefit from something merely associated with benefit, but not actually a cause. I'm going to divide our recommendations into those that are relevant early in life, those in midlife, and those in later life. Our early life intervention is education. More years of education reduce dementia risk. This suggests that cognitive stimulation is most important early in life. However, it's difficult to separate out the impact of education from overall cognitive ability. What is cause and what's simply an association? More education is likely associated with higher income, better health, better nutrition, less stress. Stress results in the release of cortisol, which is associated with impaired memory performance and reduced brain hippocampal volume. So the interactions here are very complex. But overall, as a public health measure, more education would, in general, be good for the brains of everyone in our society. Throughout our life, it's important to avoid traumatic brain injury. This has been associated with an increased risk of dementia. We've become acutely aware of this in our young sports participants, especially football players, in whom the diagnosis of chronic traumatic encephalopathy is now recognized. I'm from Philadelphia. We just won the Super Bowl. I like watching the games, but I have to admit I watch at times with a lot of enjoyment, and sometimes I'm just horrified by what I watch. But this applies to the rest of us in our daily lives. So make your sports choices wisely. Wear helmets when recommended. Avoid falls. Exercise to maintain strength and balance. And of course, use your seatbelts. So let's consider how to protect yourselves in mid and later life and focus on cognitive stimulation and cognitive maintenance. Studies have shown that people older than 65 who read and play games have a reduced risk of dementia. This finding is consistent with studies of midlife cognitive activities that find them associated with better late life cognition. Mid-aged people in one study followed for decades who traveled, had social outings, played music, created art, were readers, spoke a second language, all maintained better cognition. Regarding cognitive decline, the use it or lose it hypothesis suggests that mental activity in general might improve function. People in more cognitively demanding jobs tend to show less cognitive deterioration, both before and after retirement. In addition, a study found that older retirement age, but not the number of years working, was associated with lower dementia risk. One caution, various cognitive treatment programs have been commercially marketed. You may have heard these on the radio or television. Systematic reviews have not shown any benefit to these commercial products. Now, here's something very important. Studies suggest that the treatment of hearing loss may be one of the most powerful interventions to protect your cognitive function. Studies demonstrate a decrease in cognition for every 10 decibel reduction in hearing. In addition, the use of hearing aids has been shown to be protective against cognitive decline. So please pay attention to your hearing. Persistent midlife hypertension is associated with increased risk of later dementia. The risk is further increased if hypertension persists in later life. In general, controlling all cardiovascular risk factors is associated with a lower risk of dementia. So pay attention to the newer, more aggressive guidelines for the treatment of hypertension and take that seriously. There is convincing evidence that physical activity protects against Alzheimer's disease.
Mhm.
There's no evidence to suggest which form of exercise is best. So exercise should be part of everyone's health plan. Typical recommendations are the same as those as you would find for cardiovascular benefit. Type 2 diabetes is a risk factor for dementia. As cardiovascular risk seems to increase dementia risk, it seems likely that good control will be helpful. There's some very intriguing evidence about the new GLP-1 drugs like Ozempic that you see advertised on television all the time now, and whether these might be helpful in protecting against dementia. We need more evidence about that, but there seems to be something going on there. Alcohol. Excessive alcohol use is associated with increased dementia risk. That is clear. The role of moderate use of alcohol is being rethought. There had been a J-shaped curve you may have heard of, suggesting general health benefits from moderate use of alcohol and increased risk only for excessive use, and that has now been called into question. At a minimum, caution regarding any excessive use of alcohol should be taken seriously. Tobacco. Smokers are at higher risk for dementia. Stopping smoking reduces the risk. Even secondhand smoke has been associated with increased memory deterioration. Depression. Depression occurs commonly in dementia. This may be reactive or the result of the brain deterioration itself. Studies suggest that later life, but not earlier life depression is associated with an increased risk of dementia. There is some suggestion that the treatment of depression with medications diminishes the risk of dementia, but that's not completely clear. Social contacts. In the various forms that this is measured, whether through marriage, community groups, or friendships, social interactions are clearly protective. This seems to be consistent throughout all cultures. Air pollutants. Air pollutants of many forms are associated with dementia, including carbon monoxide, nitrogen dioxide, and fine particulate matter from traffic and industrial sources. Residential wood burning is also an association. Thus, we have another reason to support measures to improve our environment. A recently recognized risk factor is sleep abnormalities. This can include poor sleep quality, circadian rhythm sleep disorders, insomnia, or obstructive sleep apnea. There is a suggestion of a U-shaped association between sleep duration and the risk of cognitive problems, such that too little or too much sleep may predispose to mild cognitive impairment or Alzheimer's disease. So please address sleep issues aggressively with your physician. Diet. There is no clear diet for cognition, except that studies have shown that people with cardiovascular risks would benefit from a Mediterranean diet, emphasizing plant-based foods and healthy fats. Systematic reviews have not shown any benefit from vitamins, calcium, zinc, copper, omega-3 fatty acids, or antioxidants. You might have another reason to take these, but they're not protective for your cognitive state. I'll note that just recently read a report suggesting that red meat might be a risk factor, so take that as you will. So as you can see, there are many interventions you can institute to improve your cognitive state and lessen the risk of dementia, and I encourage you to follow these recommendations. Understanding the brain has been the greatest challenge for contemporary science, and the achievements of the last century are beginning to enable us to preserve our brain's health. One day, the illnesses of the aging brain will no longer be seen as inevitable, and let's hope that future generations do soon inherit that world. So thank you for your attention. I'd be happy to answer your questions.
Okay, I'm going to go on to gallery view. And if you want to raise your hand, either by an icon or waving your hand, I'll call on you. Questions? Well, here's one. What about crossword puzzles and all that they keep talking about? Is that a good thing? Does that help?
I think everything you do that exercises your mental capacities is good, but there's no one specific thing that's necessary. I mean, I think you should do what you enjoy. So, if it's painting, if it's playing chess, if it's reading a book, I mean, as long as you're doing things, I think that's fine. I mean, the brain works in a very global way, and almost whatever thing you're doing, if you're talking about crossword puzzles, I mean, it's exercising your memory, your verbal capacity, it's doing all kinds of things. But I think the general idea is keeping your brain active is important.
Okay, Vicky. Unmute yourself.
I'm working on this theory that that the whole problem is lack of blood flow to my brain, and trying to do things that increase that, so that the whole thing would be whether there's a physical cause for this rather than lack of using your brain is lack of using the blood, getting the blood up to your brain. Is there any evidence for anything like that?
Well, it's like a lot of things, it's complicated. Again, a few decades ago, that was thought of as being the main cause of dementia, and we now realize that's not true. However, if you look at people with dementia, you will find on brain imaging more evidence of vascular disease. So that seems to be a contributing factor. Now, is it the amount of blood flow to your brain? I don't think there's any evidence of that. I mean, you could be in a situation where you might have some significant blockage of your carotid arteries, but when you think of the brain in terms of its blood flow and its metabolism, your brain weighs about 3 pounds. It gets 25% of your blood flow. Your brain is incredibly metabolically active. That's the reason why it's so sensitive to lack of blood flow for a short period of time. But your body is very jealous in terms of maintaining your brain's blood flow. It'll shut down everything else and try to keep the brain getting its blood flow. So I don't think there's anything specific you can do in terms of trying to increase the blood flow to your brain. But let's say it's under investigation, and it's trying to understand what is the effect of vascular issues in terms of these issues, in terms of these diseases.
Andrea.
Thank you, Dr. Eisner. I was 2 years behind you at Penn, but
Okay.
not in medicine, architecture. I have a question for you. I'm on a board for an organization called Climate Diet, and our mission is to educate people about the impact of eating meat on the climate as well as on their health. So I wondered, might you have a citation for me about that indication that you said red meat may be a risk factor for dementia?
Yeah.
Where did that come from?
Okay. I follow a physician named Eric Topol. Is that name familiar to you? Topol. He's on Substack.
Oh, yes.
Okay, and he had an interview. I think it was an interview. Within the last 2 weeks.
Okay.
And I can't remember I can't give the name of who he was interviewing, but if you look up Eric Topol on Substack, that's where it was from, and that's the first time I've seen that. But I guess maybe it's not surprising when you consider the fact that we know that maintaining, let's say, vascular health is a good thing for your brain, and we know that red meat is probably not a good thing for your vascular health. So it all kind of fits together. But yeah, that's where you'll find it.
Thank you so very much.
Sure.
Marion.
Hi, thank you. A very enlightening talk. I have one question. Is Alzheimer's, dementia, and all the other kinds of cognitive diseases, is it genetic? On one side of my family, there's a lot of people who have had it, and I worry about my kids and my grandkids and wonder if it runs in families or what.
Well, there are genetic risk factors. There is some evidence that people who share, let's say, the wrong form of this lipoprotein ApoE gene, if they have if they carry genes from both their mother and father, or the wrong form of that, the risk of dementia starts to become very high. I think that's only about 2% of the population. However, I think there, at this point, have been over 90 genes associated with Alzheimer's disease. So, and I would assume that there's probably just a great variability about how many of these genes we all inherit. So, is there a genetic factor? Yes, there is. Do we fully understand it? No. Because again, what I would come back to is the fact that if you ask us what is the cause of the illness from our understanding today, we still are somewhat puzzled. Although this amyloid hypothesis has been very much in the news for perhaps a couple of decades and has been a focus of a lot of attention, there are researchers who think we're just going in the wrong direction, that Alzheimer's disease is not caused by these amyloid deposits and maybe something totally different. And it's possible that the research for the next couple of decades is going to just put us in other directions. So there's still so much more we have to learn. So genetics plays a role. I think probably the same way that it plays a role in many illnesses for all of us. But there could be maybe 100 different genes that we're looking at, and how many of these do we inherit? And maybe so your risk is somewhat more, somewhat less, but it's just very complicated.
Thank you.
I'm looking for questions. I don't see anybody's hand.
Andy.
Oh, okay, Andrea.
I have another question, Dr. Eisner. I've just signed up to take a course, and I don't know if it has any scientific value or not. It's called Stronger Memory, and it's been created by the Goodwin Living Foundation in Alexandria, Virginia. I wondered if you've heard of it.
I'm not familiar with it. What I'd say is that I think we all in our own lives, in the areas that we have interest, can find ways of exercising our brain. I mean, I used to tell my patients, if you want to exercise your memory every morning, just open your eyes. I mean, the first thing you have to think of is like, okay, where's the bathroom? Where's my toothpaste? I mean, you're every moment of the day, you are exercising your memory. So I've always been skeptical of commercial programs designed to help people with this. Some of them have been looked at, I think, carefully, and let's say there hasn't been much evidence that they do anything. But again, I think that the general concept of finding ways to stay mentally active in the way that you like. I mean, again, that's our emphasis. I mean, it's kind of like physical activity. If you tell someone they have to go out and jog, maybe that's not what they want to do. But if they like to bicycle, or they want to participate in a Zumba class, that's what they're going to do. That's what's going to help them. So, find your own way of staying mentally active. That's what I would say.
Thank you.
Okay, sure.
Barbara, unmute yourself.
I think I've probably heard the answer, so I've held off asking it. My husband died of Alzheimer's after about 8 years of visible issues. And 2 of my 3 children are terribly worried that they have a genetic predisposition and will get the disease. One of them in particular. Do you recommend genetic testing, or
I mean, they know all of these. The one who's so worried has read enormous amounts and knows all of these things. She has terrible sleep disturbance and she can't get it under control. And I've figured that, there is a risk and it's hard to deal with children who are that worried. Do you have any suggestions from your patients?
Right, Barbara, thank you for that question. That's a very difficult question. I'd
Yes, it
start
is.
there's a very interesting discussion of that very issue in this month's Scientific American.
Hmm.
So one of their articles is about Alzheimer's, and they went into that topic. Oh, this is very difficult. We, in medicine, if you have a definite treatment for a genetic illness, then obviously you want to be very aggressive about testing. In situations like this, where our interventions are limited, it becomes, it's just hard to know how to advise people. And I think that there's no one right answer. One of the issues you would face when you do testing is, okay, how are you going to change your future life? I think for some people, they might take that information and use it in ways they think are very positive, and say, I'm gonna plan my career choices differently. I'll, my finances differently. I mean, people might make very important choices if they had that information. There's also some concerns, though, about how the information might be used in other ways, such as if you decide you want to buy long-term healthcare insurance and the insurance company finds out that this is your risk, are they going to refuse to sell it to you? Same kind of issues with health insurance. Are you going to be discriminated against for other reasons? I'd say it is but first of all, I'd say it's an individual decision. People have to come to it themselves and try to decide what do they really want to do. But I think that it should only be done after very careful thought, understanding how are you as an individual to deal with it. I mean, often when genetic testing is done for illnesses, you have to have a lot of psychological support around getting this information. But it's a fair question, and I think that it's something that only you as an individual can answer about what you want to do. Do you want to do this, or do you not want to do this? Thank you, Carl.
Andrea.
Sorry, Dr. Eisner. I have another question.
Yeah.
I've heard Dr. Barry Gordon, who you may know from Hopkins in Baltimore. He's head of the neurology department there. I've heard him speak, and I think I came away with the information that it's, at the moment, perceived to be passed through the mother if it's genetic. Have you heard that?
Well, again, in terms of the gene that we pay the most attention to, no, that's not true.
Okay.
It's the lipoprotein ApoE gene is something that we all have. There are, I think, 3 different variants of it. So we all have a variant of it. And it's really just a question of which variant is passed on to you as an individual.
I see.
No, it's not a question of the mother. No.
Thank you.
No.
Elsa.
So, Dr. Eisner, I have a sister who is 86 years old who has been diagnosed with mild cognitive impairment about 5 years ago. Her memory is getting worse and worse. And as you described, she functions on a daily basis fine, except that she can't remember anything. So she can't keep an appointment by herself, etc. And at first, my family and I thought we needed to get her diagnosed by a neurologist. But at this point, I'm thinking, she doesn't know. She knows she has terrible memory loss, but she doesn't know that she's on the road to something else. And I'm thinking that it's probably not worth investigating and telling her that she has this disease or whatever, so we're going to give her this medication, rather than just letting it go and let her be happy in the knowledge, her knowledge that she's not going to suffer further. What do you have advice for that from your patients?
Right. That's a good question. I think there are a couple of sides to that. The first would be, are we sure what her illness is?
No.
And the reason I say that is because although most commonly when people present these kind of symptoms, we come to the conclusion that they have Alzheimer's disease or something similar to that. But there are times when in the process of investigation, which is typically a series of blood tests and a brain scan, we come across something else. And someone has an endocrine problem, a metabolic problem, they have a blood clot on the surface of the brain, they have a benign tumor, they have abnormalities in the cerebral spinal flow, and we find other treatable causes. So I would say that whenever someone presents with these symptoms, they should undergo an investigation once to rule out other possibilities.
I should say that after that period, about 4 or 5 years ago, she was examined by a neurologist, and all these other things were ruled out at that time.
Right. Okay. Well, I think that's good. That's very important to have done that. And then what to say? This is I think, a very difficult philosophical issue that I face as a physician. Decades ago, it was the norm that people were often not told the truth about their health problems. It was often the case in people who had cancer. I see people nodding their heads. You probably maybe had parents who had a health problem and no one ever told them really what it was, and physicians often didn't share that information. So there was a great philosophical change in terms of saying that we should be very honest with our patients. We should tell them exactly what is happening. And I followed that philosophy with this exception, that people who had significant dementia of whatever type, telling them all about their diagnosis, I think, was often not helpful and perhaps very cruel. Now, I would always share information with the patient's family. And as a matter of fact, with my patients, the most important part of every visit I had with my patients was always talking to their family, getting information from their family, counseling their family. They're the ones who fully have to understand this. But when someone has limited understanding, and perhaps someone who might respond in a very catastrophic way to hearing this information, or perhaps someone in whom you would give them the information and because of the memory deficit, just a few minutes later wouldn't even recall the conversation. I think you have to be a little, I more cautious about being honest with them. And I think that's somewhat of a controversial approach. And I had some families who had a lot of trouble understanding that. But I think as a physician, you're always trying to figure out what can this patient hear? What do they need to understand? And I think there's situations where you don't tell everyone the full story. And I don't know how you think about that. What do you think of that?
I think you've sort of corroborated my thinking that she doesn't want to have Alzheimer's or anything like that. And she doesn't think she's going to. So unless there was something in the offing that might really help her for a period of time that we could afford, that would be a different story. Then it might be worth it to go through. No, but my inclination is to let it be and not say anything.
Yeah, see, and I think that brings up the issue of these new treatments that we're talking about that are now available. Their benefit is, as I described, is modest. They're not wonder drugs. We don't really know what happens the long term with them. There are no studies that go back, go on for many years. There are significant risks, perhaps acceptable to some people, but there are definitely risks, brain hemorrhage, brain swelling. So, to choose this course of treatment, and again, something where it's not like we're just handing a couple of pills, but we're saying show up at the office every 2 weeks to get an intravenous. You have to really decide that's something you want to do. And I don't, if that was me right now, I'm not quite sure what answer I would give.
Thank you.
Any other hands? I don't see any. Wave them. All right. Well, I don't see any more questions. Marilyn?
Yes.
Conclude the meeting.
Well, I hope you found this session interesting and informative, and that it was worth Dr. Rich Eisner's time as well as your time. And thank you, Rich, for doing this. And we have a little token of our appreciation to give you. I will be bringing it up to your condo sometime later today from our salon group members.
Thank
So
you.
thank you very, very much. And I appreciate all of you being here and being interested enough to ask questions. Thank you.
Dr. Eisner, I thought that was great.
Thank you, everybody.
Thank you.
Thank you, Dr. Eisner, again.
Glad to help
All
out.
right. Look for Marge's notice, everyone, about the date for March. Okay.
Thank you
Stay safe.
all.
Thank you.
Before you go off, would you like for next month, Kathleen McGinnis, who does do aging and aging in place and sources for aging, which is her expertise, or you had selected,
Yeah.
Camino Trail.
Okay, Marge, let's you and I discuss it.
Okay, I just thought I'd get a consensus from the group, but that's okay.
Okay, we'll get it another way.
Okay.
All right, bye, everybody.
Bye.
Stay dry.
Right.